Joining us tonight. My name is Lou Kovach. I am the Young Physician Liaison to APMA's Health Systems Committee. It's a pleasure to be your moderator this evening and welcome you to this evening's webinar on Understanding Medicare Advantage. This presentation is the third installment of APMA Reimbursement webinar, and it is being recorded. You can access this recording at www.apma.org/webinars. The fourth installment of APMA's Reimbursement webinar series will go over Medicare provider enrollment issues for podiatrists, and this is scheduled for Tuesday, April 8th at 8 p.m. Eastern Time. Also this Thursday at 8 p.m. Eastern Time, we have APMA's ICD-10 is Here webinar. The series continues with a presentation on diseases of the musculoskeletal system and connective tissue, M00 through M50, Part 2. You can sign up for these webinars and more at www.apma.org/webinars. So let's get started tonight. Again, the topics for this evening are Understanding Medicare Advantage. We are pleased to have with us Kelli Beck and Kristen Valdes. Kelli is an attorney with the law office of Mark S. Joffe and has been a consultant for APMA, focusing on health systems for over a decade. And Kristen is the Vice President of Operations and Technology at XL Health, now United Healthcare. In her current role, Kristen is responsible for data services, data warehousing, reporting and analytics, Medicare research and policy, payment integrity, and the Special Investigations Unit. She has been with XL Health for more than 10 years. This presentation will last about 50 minutes, and we should have time at the end for questions. If you would like to ask a question, please write it in the question box located in your webinar toolbar. And it is now my pleasure to turn it over to Kelli and Kristen.
Thank you. We will be going a little later in the presentation. Most of the presentation will be questions and answers, but I thought we'd start with the basics. Sorry, my slide isn't forwarding. I thought we'd start with the basics to establish a common understanding of Medicare Advantage plans. Let me see if I can get this forward. Okay, well, it's seeming to not forward. I'll talk first about the nature of the plans. Medicare Advantage plans are private health plans that basically administer the Medicare benefit. They aren't supplements. Supplements coordinate benefits with Medicare by paying the cost sharing or co-payments, but Medicare Advantage plans actually stand in the shoes of Medicare and administer the Medicare benefit. I've heard them referred to by physicians as Medicare replacement plans, but it doesn't really replace Medicare. The individual is still Medicare entitled. The program's just administered by the plan. Medicare Advantage plans have to cover all Part A and Part B benefits. They also have to offer Part D, and that's the drug benefit. And they have to comply when they administer the benefits with all the relevant local coverage decisions and national coverage decisions. They do have additional flexibility, though, over what you see in Medicare fee-for-service. For example, even though they're covering the same benefits, they can impose utilization review requirements that Medicare fee-for-service doesn't impose, like referral requirements or prior authorization requirements. They can also review medical necessity in instances in which Medicare fee-for-service would automatically make payment. For example, instead of just automatically paying for diabetic shoes every time an individual is eligible for them, a Medicare Advantage plan can actually review the medical necessity of the shoe. Medicare Advantage plans are not required to pay contracting providers the same amount as original Medicare. They pay according to their contracts, and they can choose to cover benefits beyond those under Part A and B. And the most common benefit that they choose to cover is cost sharing, deductibles, but they can offer additional benefits such as services that wouldn't be covered under Medicare fee-for-service. Medicare Advantage organizations are state-licensed insurance companies, and the state has the ability or retains the ability to regulate solvency and licensure of Medicare Advantage plans, but that's about it. Other state laws regulating the plans are preempted. So Medicare Advantage plans do not have to pay with state laws regulating like prompt payment or recoupments or external appeals. There are a number of different types of Medicare Advantage plans. The most common type is coordinated care plans, and the coordinated care plans are HMOs, and they can choose to offer a point-of-service benefit, local PPOs, and regional PPOs. And regional PPOs cover an entire region designated by CMS, and they have a little bit different requirements with regard to network adequacy. The other types of plans that aren't as common are medical savings accounts and private fee-for-service plans. Private fee-for-service plans, in some instances, are not required to have a network of contracted providers at all, and in all instances, they are open network plans. One of the subsets of the coordinated care plans, and it's important to talk about tonight, is special needs plans. Special needs plans are coordinated care plans that limit their enrollment to individuals who are eligible for both Medicare or Medicaid. They can choose to limit enrollment to individuals who are in skilled nursing facilities or those with certain chronic conditions, such as diabetes or congestive heart failure. They have additional regulatory requirements over and above those for regular Medicare Advantage plans. All the special needs plans have to follow a model of care and set forth and have approved by CMS how they're going to do care coordination and take care of their high-risk populations. And they have to follow that model of care. The reason I go over this is it's extremely important to know what type of Medicare Advantage plan that you're dealing with in order to understand the plan's obligations and your rights. Every membership card indicates the type of Medicare Advantage plan that the individual is enrolled in. So it'll say, for example, private fee-for-service or HMO. Another really important thing to understand is your relationship with the Medicare Advantage organization. You can be in the network, that is, you're a contracted provider. You can be out of network. You have no contract with the plan, but you're eligible to provide services to members, or you can be a deemed provider. And this applies only in the case of private fee-for-service plans. They're providers who furnish non-emergency services to private fee-for-service members. Basically, if you know or should know that a member is in a private fee-for-service plan, and because it's on their membership card, you should know that, and you furnish services, then you're a deemed provider of the plan. And the important reason to understand your participation status is to understand the sources of your rights and responsibilities. For example, if you're a contracted provider, there are some laws that apply to you. For example, Medicare Advantage organizations are required to provide all physicians the right to appeal a termination decision. But most of your rights and your obligations are actually set forth in that written contract between the Medicare Advantage organization and you or your practice. If you're a non-contracted provider, most of your rights are derived from the law. And if you're a deemed provider, your rights are derived in part from the law, just like contracted provider, but they're also derived from what's known as the plan's terms and conditions. And these are posted on a website, and all providers who provide services to a private fee-for-service member are deemed to accept the plan's terms and conditions. So given that, I'll talk a little bit about why plan type and participation status are so important. And these are just examples. For example, if you look in the plan type is an HMO, if you're a non-contracted provider, you can understand that you're probably not going to be paid by that HMO to furnish services to a member. However, if the plan type is a PPO, you'll know that beneficiaries can receive services from any Medicare-eligible provider, and the organization can't require prior authorization from non-contract providers. In fact, in any kind of open network Medicare Advantage plan, you would know that the plan is obligated to pay non-contract providers what they would have received under Medicare fee-for-service. And you'll also know, as a non-contracted provider, that you're prohibited from balance billing Medicare Advantage members. There are also, for non-contract providers, prompt payment laws that apply to them that don't apply to contracted providers. So with that as background, Kristen, do you think I missed anything, or is there anything you'd like to add before we go to Q&A?
No, I think you covered it nicely, Kelly.
Okay. Okay. I think, Kristen, since XL Health Care Improvement Plus was started by a podiatrist, our participants would be really interested in learning about the background of the organization. Could you talk to us about that?
Oh, I'd be happy to. XL Health was founded as a company by the name of Diabetics, and one of our founders was, in fact, a podiatrist. We started as a disease management company, and we held contracts for government demonstrations as well as private plans with HIP, for example, the Health Insurance Plan of New York, to provide care coordination and disease management services for our members who were suffering with diabetes. We also specialize in congestive heart failure, COPD, and ESRD, which, as you know, are some of the highest costing diseases plaguing our country today. We have a very specialized focus on how we coordinate and handle care for all of those beneficiaries living with those chronic illnesses. And our model of care, which we are obligated, as you heard Kelly talk about, to supply to CMS on an annualized basis, has been deemed best in class. So we're very proud of the foundation of our plan, and it did make sense for us to go into Medicare Advantage when we saw that they were offering the special needs plans or the SNP programs, because we felt that our services really aligned nicely with becoming an insurance plan.
Thank you. Let me turn here to coverage. APMA gets a lot of questions from physicians who are concerned that when they feel like a Medicare Advantage organization isn't covering services that are covered under fee-for-service Medicare. Could you respond to that?
Sure. We are obligated to cover every Medicare benefit that a fee-for-service enrollee would be entitled to, and that's simply under the basis that Medicare beneficiaries have an entitlement. So any Medicare Advantage or private Medicare plan has to offer at a minimum those services covered by Medicare. Plans like ours specialize and customize our benefits towards the needs of the beneficiaries that we enroll. So we don't just cover what standard Medicare covers. For example, we cover more podiatry visits in a year than what standard Medicare would cover within our chronic SNP plans. And we do that because we understand the benefits of getting our members to podiatrists on a regular basis, and several of our disease management interventions are based around that. So many of our benefit plans have been customized or tailored to the needs of those chronic conditions.
Okay. And I'll just add, for podiatrists who are asking, you can go, there's a CMS requirement that every Medicare Advantage organization maintain its summary of benefits online, and those are pretty easy to find, so you can just look them up online. And you should also know that Medicare Advantage organizations are required to submit the benefits they propose to offer to CMS, and CMS approves those. So in most cases, when we get questions about whether a Medicare Advantage plan is covering something not covered by Medicare, the answer is a little more complicated than that. They are not required to offer to cover them in the same manner or circumstances. They have to comply with local coverage decisions and national coverage decisions, but for contracted providers, for example, they might bundle a service that Medicare fee-for-service doesn't, or pay for it differently, and consequently the physician might see it as not covered. But as long as the beneficiary can get the benefit and doesn't have to pay more than a cost sharing, it is considered covered.
And Kelly, that's a great point. Just to add on to that for our plan, there's another obligation that we have where if a service is going to be denied on a claim, the explanation code or the explanation of payment on that form is required to be specific. And it needs to be specific so that it's clear to the provider if, in fact, the denial is because it's not a covered benefit. In fact, the explanation code that we use is, this is not a covered benefit. So I think you can see from the explanation codes on those remittance forms that you receive, you should be able to determine pretty specifically when things are denials for benefit coverage versus when things are denials for specific local coverage determinations or other reasons. So that's a good indicator for you to take a look at. But as Kelly said, the summary of, if you get something that says this is not a covered benefit and you look up a summary of benefits online, it's usually an indication that there's some type of an error and that you should reach out to the plan.
Great, thank you. Another area we get a lot of questions about is the volume of medical record requests. Can you talk about why or some of the procedures around medical record requests and audits?
Sure, I'd be happy to. We get a lot of questions around this as well. So there are many reasons that Medicare Advantage plans are required to review medical records. We look at them for purposes of risk adjustment, quality improvement, STARS programs, fraud, waste, and abuse. A lot of the common misnomers are things that are published by CMS specific to individual programs. So for example, CMS has a RAC program, and there are publications around the number of charts that can be requested as a result of the RAC. What a lot of folks do not understand is that RAC is only one of the areas of CMS that requests submission for medical records. As we just talked about, we have a whole series of needs that are beyond what we would be doing for fraud, waste, and abuse or RAC-related type audits. So those limits do not apply to Medicare Advantage plans, but most Medicare Advantage plans will do their best to limit the number of records to a provider and try to space them out over time. Each of the letters that you receive requesting a medical record must be specific with the reason that that record is being requested. One of the things that a lot of plans are doing, and that I can speak to our plan specifically, is we do allow multiple submission options. So mailing typically is not your fastest way to get your medical records in, especially if there's an audit process going on. But there are usually dedicated fax lines. You are always allowed to provide a CD. However, with password protected, it's often hard to match up a password with a protected CD. We do coordinate with third-party copy vendors, and our best option, which actually on this slide says future, but I neglected to let Kelly know that we are live, and we have our highest growing submission rate through our provider portal or our web portal. So we did go live, and we're happy to announce that that's working wonderfully. But the reason that faxes and electronic records tend to work better for health plans is because they can automatically be scanned, indexed, and received into a technology system. The old days of mail and CDs tend to make things a little bit slower, and they're harder to handle or manage. So we do prefer electronic submissions for our plan specifically. The other thing we can talk about is what that request process looks like, because I think that there has been some historical confusion. So we've laid out specific to our plan for you to help you understand that it is a science, not an art, to managing medical record requests. We do allow 30 days for submission. We are obligated to allow that. At day 15, we send a reminder letter, and that reminder letter will say, hey, you know, we requested a chart. We haven't received it yet. If you've already submitted it, please disregard this request. If for any reason the documentation that we're requesting is insufficient, we do allow an additional 30 days to submit documentation relevant to that request, although each of the letters is specific to what the needs of the request are. We do find sometimes that providers may get confused between what's required for a prior authorization of a service as compared to a full retrospective audit, where we're looking at something that could be in a Medicare vulnerable area that we're obligated to review. We do submit, if you do fail to submit your medical record, we do issue a demand letter. And that we do give a grace period because we understand a lot of folks do use the mail. But if for any reason we don't receive that record, a demand letter is sent and the claim retraction is issued. Once that medical record is received, even after the claim retraction, it will come in. We will perform the review, and once the review is completed, we will then process the claim according to the results of that review. So we, at this time, don't even enforce that from a timeline perspective. We do want to make sure that we are fair with all of our providers related to their opportunity to have their claim reviewed.
And
the other, go ahead.
I just wanted to add, I mean, Care Improvement Plus is great because it follows almost the same system as Medicare fee-for-service. I just wanted to add, not every Medicare Advantage organization does the same thing with regard to its contracting providers.
Yeah, that's a great point. We do talk with lots of hospital associations and provider groups and large groups, and what we hear often is that Medicare Advantage plans can create their own rules. We know they can't create their own rules, and in fact they're governed very heavily, but we also know that there are some plans that are performing much better from an operations perspective than others. And so what we hear a lot of is some plans that are not performing from a timeliness perspective or with the embedded quality that they really needed to, and we understand that that's frustration for a provider. So one of the additional things that we did in listening to our provider communities was on our portal we provide statuses. So every day someone from your office could look at any audit being performed by Care Improvement Plus or any request for records. You can see the status of that audit. You can see when the records were received, and you can upload them right there. So we can ensure that from a timeliness and a visibility perspective that you're not gathering a whole bunch of paperwork, but you have everything in one location. We do also pay for medical records, and this has been I will say it's been a very hot topic in the industry. So payment for records, we are a federal program, and we do pay rates published in the Federal Register. A lot of the third-party copy services do not like those rates. They do not feel that they are adequate, and in those cases we do try to work with them to submit records electronically because it does take away a lot of the cost of the mail, the cost of the copying, the cost of the paper and materials. We do have a form for obtaining that payment, the medical record payment form. Once we receive it, we validate the records are here, and we process the payment within 30 days. With the electronic medical portal, we actually can generate invoices or our providers can generate invoices automatically based on the confirmation of the upload. So we actually encourage providers to use our portal to ensure that they not only have a faster, speedier service from our health plan, but they're also compensated adequately. In our post-payment review process, we do perform a review within 60 days of receiving the record. Again, if the record is incomplete, the timing will be a little bit longer because we do allow an additional 60 days to submit additional documentation. We do utilize Milliman care guidelines, Medicare coverage guidelines, and local and national coverage determinations. We also take into account the inpatient-only procedure lists. Our medical records are reviewed. We try to review them once so that they do not get audited multiple times throughout the lifespan of a claim. So we do use certified coders as well as nurses and physicians, and if necessary, a medical director in order to review those claims holistically. We do send determination letters. It must include, and it is a requirement that it includes, a comprehensive rationale for the determination if the determination is not in your favor. We have to provide to you the reason for reopening, the rationale, the time frame to submit, which allows you 45 days to voluntarily refund any overpayments, and your appeals rights. And that's very important because we do want to make sure that providers understand that they do have a voice, and if they feel we've made a mistake, we do want to hear from you.
Thank you for that comprehensive answer. That's very helpful. I'd like to turn now to payment, because APMA also gets questions from physicians who are concerned because they aren't paid in the same manner and amount as they would have been paid under Medicare fee-for-service. Could you respond to that?
Sure. A non-network provider for a Medicare Advantage plan must be paid the same amount and in the same timelines as Medicare fee-for-service. We, again, do cover additional benefits, but we must cover at a minimum what Medicare would pay for that provider. So the non-network provider payment is issued. There is no obligation to follow any plan rules if you are a non-network provider. However, if you are a network provider, CMS views this as the contract is between the provider and the plan, and they do not want to overstep that contract. They want us, obviously, to have a good working relationship and follow good rules. And so we do pay according to our contract for the networks.
Okay. And I know, just to add, a lot of Medicare Advantage organizations for the network providers might use different edits than Medicare fee-for-service. And so there are times when providers are a little bit surprised when they get payment and it's not in the same form that it would have been under Medicare fee-for-service. I'll turn now to fee discrimination, which has been a major concern for doctors of podiatric medicine. Fee discrimination is when DPMs are paid less than MDs or DOs for providing the exact same service. Could you talk about Care Improvement Plus's practices in this regard?
Sure. Care Improvement Plus really tries to mirror its programs and its payments specific to what Medicare reimburses. So you won't find any differentials within any of our benefits, which again the benefits would need to be approved by CMS. But we do pay specific to how Medicare would pay. So if the reimbursement rates or fees are different for physicians as they are for nurse practitioners or any other credentialed licensed physician or practitioner, we will pay according to exactly those rules that Medicare pays.
Okay. Another area we get a lot of questions is, and this is something that's come up recently, is termination for Medicare Advantage organization networks. And actually, Kristen, I'll let you off the hook, and I will address this question because I represent a lot of the plans who have done these terminations. I also represent a lot of providers who have been aggrieved by these terminations. Some of the plans that have done these terminations, I think we're all aware of, are WellPoint, Humana, Anthem. And in fact, there's a trend towards smaller networks not only in Medicare Advantage, but in the commercial world, particularly in healthcare reform, as a cost savings measure. APMA actually wrote to CMS raising a lot of issues with this after getting a number of complaints from members. And CMS pointed out that what they regulate is network adequacy and the procedural issues. But Medicare Advantage plans have great flexibility in deciding which providers they would like to have in their networks. And CMS noted in its letter that in response to the complaints regarding network adequacy, they had run their programs to make sure that the plans who had terminated providers were still meeting the adequacy standards, and in fact they were. In terms of the procedural requirements around member terminations, members have to be notified, or provider terminations, members who regularly see those providers have to be notified 30 days in advance that their provider is being terminated from the network. The providers have to be notified where they're being terminated without cause, and we were seeing a lot of without cause terminations, at least 60 days in advance of the termination. These notices of termination are required by regulation to include the reason for termination, and that applies even if the reason is, in fact, without cause. But if the reason for termination has data involved, for example, profiling data, that data has to be provided to the provider. And not necessarily the raw data, but they have to explain the standards against which the provider was measured. And if they're terminated, for example, because the plan had too many of a particular type of specialist, they have to provide the number and mix of physicians that, in fact, the Medicare Advantage organization needs. And with every termination, the physician does have a right to appeal the termination decision. And the appeal has to be heard by a hearing panel where the majority is peers of the affected physician. And peers doesn't necessarily mean the same specialty. In fact, it absolutely doesn't mean the same specialty. It means other physicians. And this right to appeal, there aren't many regulations about this. There's certainly no right to appear in person. There may be no right to actually talk on the phone. They may request instead that you provide a written explanation. In fact, the right to appeal doesn't have many teeth to it, other than the physician is supposed to get due process. In the letter that APMA wrote to CMS, CMS did respond that if there were situations in which physicians felt they didn't get the opportunity to present their case, either in writing or otherwise were denied due process, that they let the regional offices know about those specific instances. So the next one's for you, Kristen. Could you talk about what makes an effective appeal, or what would be the best practices in filing an appeal with a Medicare Advantage organization?
I'd be happy to. There are different appeals processes for in-network and out-of-network providers, and it is important to know what those appeals and those level of appeals are. For a network provider, the provider has the right to appeal, and once reviewed by the plan a second time, although it must be a separate independent unit or an individual who are performing that review to allow for fairness to the provider, the plan determination stands. It's at that point that most contracts would govern next steps, whether or not that moves towards arbitration or any other type of action. For a non-network provider, there is an independent review entity that CMS has awarded contract to in order to perform that independent review once the plan has performed its review the second time and determined to uphold the decision for the denial. If obviously the plan on second review determines that the appeal will be overturned and the claim will be processed for payment according to the rules, then of course the payment will be remanded to the claims shop for issuance within a very short period of time. Effectuation must occur very quickly. However, if the independent review entity also agrees with the plan's first and second determinations, the provider does have the right to go to the ALJ. And the ALJ will create a hearing with the judge, and we will go through the attributes of the case. The ALJ will then issue a determination. Again, if that is upheld, there's always a final appeal to the MAC. So there are several levels of appeal, which can be very lengthy in process for non-network providers, but they do afford due process to providers who are non-contracted, and that's simply to ensure that a plan cannot penalize a non-contracted provider for not being contracted. The appeals process information is included on the denial letter and on the website, and what you'll find is most plans also included on their remittance or payment forms. So the appeals information is pretty readily available in terms of process, where to submit, what addresses to use, or phone numbers. And coverage issue. If it's a coverage issue, you should include a blinded fee-for-service remittance for the exact same service, showing that it was covered by fee-for-service. This pretty much takes the guessing game out. It's very clear to the plan what it is you're trying to convey, and your appeal will be processed, in terms of how fee-for-service would pay for those covered benefits, if it is in fact a coverage issue. And again, I would encourage you to look at the explanation code, or what they call the CARC and RARC, which are the adjustment reason codes, on your remittance form in order to know how to address the argument that you'd like to make within your appeal. For the appeals process, we follow an appeal and reconsideration guidelines as they're outlined in the PCUG manual. MAPD plans are audited to ensure that this process is followed. And I think, Kelly, I may have a descriptor on the next slide.
I think this is the only slide I have. This is the
Oh.
last appeal slide I have in there.
No problem. So for the PCUG manual, it is important to look at those guidelines, and as most plans will in fact follow those guidelines as they're obligated to under Medicare.
And one thing I would just add, with those non-contracted provider appeals, one of the important requirements is, in order to be eligible to use that appeal process, the provider has to sign a waiver of liability. They have to indicate that regardless of the outcome of the appeal, they will not hold the member responsible for payment of the claim that's being appealed. We talked a bit about best practices with regard to appeals. So in that sense, we talked about resolving problems with coverage. But what about resolving other kinds of problems that a physician might have with a Medicare Advantage organization? And I'll give you an example, which actually is a coverage issue, but it's not really addressed by appeals. What if a provider consistently gets denials for a particular benefit and may or may not appeal them, but wants to address with the plan what's the reason for the denial? Or what if the provider has some other type of problem with the plan? Could you talk a little bit about where they would go to get those problems resolved? I think a lot of physicians just kind of throw up their hands. They're not quite sure how to contact the plan or who to talk to at the plan in order to resolve problems other than appeals.
Sure. And there are several avenues that you can get in contact with the plan, and we see that different providers and their office staff have different pathways that they find to be effective. On our membership cards, you are provided with customer service phone numbers. There is a provider customer service line. You can contact them for any questions. If they do not have an answer to your question, we use a very detailed workflow routing system that will route the question specifically to the person who has that answer and who will supply it back to you, and you will receive a call back. We find that folks also who are network providers do reach out to their provider network representative who has a wealth of knowledge and information related to questions that have been asked and answered previously. Our group specifically provides internally a knowledge management library where when providers have questions, anyone who is asking a question through either our provider services lines or our provider network staff, those answers can be easily addressed and often can be given out to the provider immediately because they are documented. We can fax you or email you information pertaining to the answer to your question. But it is important to look at that provider services line and contact them. Sometimes when you contact an individual, because it's not handled through a workflow system, your request could in fact get lost because if someone forgets to or gets distracted and doesn't send that email to the right person or get it into the workflow queue, you may not get a response to your answer. So specifically on appeals, though, we do require that you submit appeals in writing using any of the various methods that we provided previously. It is important in order to route those appropriately and get them worked from a timeline perspective. For any reconsiderations, again, if you have any questions pertaining to the reimbursement on any type of covered service, you are allowed to contact the plan through those provider services lines, and we can resolve those issues for you by phone.
That's helpful. I think it's important that people kind of understand what's appealable and using the available process rather than just going directly to their provider rep with every problem they have. I think it's also important that if they are making an appeal, that they make it very clear that they are appealing and they follow the directions for appealing. And if I can, I'll just provide an example. I have a client who sent me something to look at. And what had happened was a provider sent a 6-page letter to the CEO of the health plan telling the plan how many laws that it was violating. The CEO office opened it, saw that it was talking about violating laws, and routed it to the legal department. Legal was very busy, and it sat on a desk for a while until it got sent to me. I looked at the letter and realized that the legal claims had no merit. They really didn't understand the relevant laws and set it aside for a while. Later, I picked it back up and realized that on page 6, they indicated that they were trying to appeal the claim. So their appeal was very, very late. It got processed slowly. So certainly, I think it's very important for everybody who is filing an appeal to go to the website, look and see where appeals get sent. The first thing in their appeal letter should say, I'm appealing X claim, so that it's very clear, and that's the best way to get an appeal processed in a timely manner.
That is an excellent point, Kelly, and it's a fantastic point. If it is unclear what you're trying to convey, there are all kinds of issues that could be created by the health plan in trying to route your request to the appropriate department to handle it. Oftentimes, the appeals unit is completely segmented and separated from traditional operations where we try to resolve any type of payment dispute or reconsideration. And that's by design. And that's in order to ensure that providers do have due process and an independent group reviewing it. But if it's not labeled or marked as an appeal, oftentimes it's very confusing for anyone who is intaking that information to determine what action you intend to have. So, you know, I've seen providers do everything from create a customized rubber stamp and put appeal right on it to being able to indicate in their letter that this is an appeal, in which case you will be notified and triaged by the appeals unit if it is not a valid appeal. And appeals and the process are really designed to cover denials in service. You know, if you have an issue where you were paid $35 and you felt that the standard rate was $37, those are not appealable issues. Those are things you should contact the plan for reconsideration request, and that way we can route your issue. But documenting an appeal as an appeal is extremely helpful in getting things to the right location.
And I might add, since you brought up the issue of questions about payment amount, that there used to be an external appeal process for disputes regarding payment amount. So, for example, if you were a non-contracting provider and you were entitled to 100% of Medicare fee-for-service payment and you felt the plan didn't pay you that, you would first appeal internally to the plan, and then if you still had a question or didn't like the plan's response, you could appeal to an external entity. And CMS just recently cut the funding for that external entity, so those appeals will still go to the plan, but there isn't really a second level of review. And frankly, and maybe you can correct me, Kristen, it seems like it ought to be a fairly easy issue to resolve for a plan to see if it is the Medicare fee-for-service amount. Do you run it through a pricer or something like that?
Yes, there are several pricers that are specific to Medicare, as well as local coverage and national coverage databases and rules engines that we leverage. Typically, if a complaint comes in related to pricing, it is usually very easy to resolve. Typically, those that are more complicated are where the provider contract with the plan creates something that is customized outside of standard Medicare fee-for-service with specific groupers and other things. That's typically more complicated, so we always advise providers and our provider network folks to stay away from those very complicated setups, or using what we call, ghost codes or codes that are made up that fall into CPT or ICD-9 categories in order to describe services that are outside of the standards. So we do encourage folks to really make sure that your coding is appropriate. It should be consistent with how Medicare is paying you, and we should be able to resolve those issues relatively quickly.
Great. Thank you very much. That's the end of my questions. Luke, do we have questions from our participants?
Yes, I actually have a first question up right here. It says, we find it very difficult to obtain our fee schedules for Medicare Advantage plans. Do you have any recommendations on how to obtain our fee schedules?
Kristen, I'll let you answer that. I assume that's for a contracting provider looking to get the fee schedule.
Sure. So for a contracted provider, for your fee schedule, and most of our contracts are a percentage of Medicare, so we could supply the fee schedules with the multiplier or subtractor, depending on the contract and the service, which could provide those payment rules. A simple request to the plan would allow for us to provide that to you. For fee-for-service, obviously, the fee schedules are published online. They are available on the CMS website. And so for non-contracted providers, you can certainly go to the CMS website in order to get your fee schedules annually.
Yeah, and I'll add, as somebody who sees lots and lots of Medicare Advantage provider contracts, I think that's a very common practice, is basing contracting provider payment on the Medicare fee schedule. So there should be ways, extrinsic external to the plan, that the fee schedule could be figured out if that's the case.
Okay, thank you. The next question I have here is, what if Medicare Advantage organization says it does not cover Medicare diabetic shoes? What should we do?
So one of the first things that needs to be determined is because there are limitations on how often Medicare beneficiaries can have diabetic shoes, we need to determine that there's not another provider who is billing for those shoes for the beneficiary within the amount of time. So if the beneficiary has seen a different provider, it would often be difficult for you as an individual provider supplying the shoes to know whether or not a claim has already come through, and therefore the denial is because of a benefit overage versus a denial in service. So you are allowed to request from the plan the answer to the question on whether or not this is a coverage maximum that has been met or a denial in service. And those are important because then you have the right to go back to the beneficiary and indicate that there was another claim submitted, and while that HIPAA-protected information cannot be supplied to you, it can be supplied to the beneficiary. If the beneficiary does want an additional set of shoes earlier than we're allowed to pay for them under Medicare, then the beneficiary is obligated to pay for those. However, if the beneficiary feels that there's been some type of an error, then they need to contact the plan, and that's something we would need to look at under fraud, waste, and abuse, and or whether or not there was a claims processing error from a provider billing or matching issue. So we could take a look at that, but I would strongly recommend you decipher whether or not it, and usually, again, the provider remittance will tell you whether or not it's a denied service or it's an overage of that, because many Medicare, especially supplies and equipment, they do have times that you're allowed to provide them. So, for example, a power wheelchair once every 5 years. Just a good example. So if the plan has had that member for more than 5 years, you as a provider may have not, you won't know that a claim has already been fulfilled, meeting that member's requirement for payment for that type of equipment. So we do suggest that you reach out to the plan to determine those two, or look at your remittance form and then have a conversation with the beneficiary. Just to add on real quick, which we talked about previously, if it is in fact a denial of service, we do know that Medicare covers diabetic shoes for diabetics. We do recommend that you send in an appeal with, again, a redacted remittance showing that Medicare fee-for-service does cover that service. That's going to give you a very strong appeal in order to have your point heard and have it be worked quickly.
Thank you. Moving on to the next question, it says, if I am an out-of-network provider, am I required to give records to the plan with large blanket requests? If yes, may I charge copying fees prior to furnishing these records?
Okay, so a couple questions or a couple comments on that. There are certain types of medical record requests that will come to you that you are obligated to provide. Those would include things for payment integrity audits or medical necessity audits or prior authorizations. If the blanket large volume requests are coming in order to do things like look at STARS programs and quality programs, basically in order to obtain things like lab values which are not readily available, or whether services were performed, and or to determine diagnosis coding for beneficiaries, which could be within your notes but not coded on your claim. You are not obligated to provide those records. However, most plans will pay for all records. Now, your question specifically was whether or not you could request payment prior to the records being performed. That typically does not happen, and plans do not allow for that. However, you could negotiate that with a plan if it is a non-required type of record. If it is for an audit, if you do not supply those charts within the appropriate timeline as specified in the letter because you're holding out for payment, I can assure you that your claim will be retracted and offset. So no one likes that process. So we do encourage that for record requests that are mandatory, that you do supply them in the timelines that are afforded to you, and that you do contact the plan to determine the reimbursement for those charts, and they will set you up for payment. And like I said, for us, it's pretty simple because when you upload the records to the portal, an invoice is generated automatically, and the payment and check will be cut to you within 30 days.
Yeah, that's a really good answer, Kristen. And I think just to add, to make it straightforward, if Medicare fee-for-service requires you to provide those records, then you should provide them to the plan. So, for example, under Medicare fee-for-service, you're required to show that you are entitled to the amount that you have billed, because the plan pays the same amount as Medicare fee-for-service. If you do not show that, the plan doesn't have to pay you or could recoup payment if you don't provide those records. So if it's a use you don't see in Medicare fee-for-service, like as Kristen said, looking for diagnostic data or for quality data, those are the instances where you could request payment and don't have an obligation to furnish it.
Okay. Next question, if no contract exists, doesn't that mean Medicare Advantage plans have to pay higher, at least non-par rates on Medicare fee-for-service?
So, Kelly, I don't know if you want to take that one, but the way that, and I think I'm understanding the question, a non-contracted provider is therefore, and who sees a beneficiary enrolled in an MAPD plan and furnishes services, is a deemed provider, which effectively means that your claims will be processed according to Medicare fee-for-service, where there is also no contract. So you cannot be paid more or less than Medicare on those services. You will have your claim processed according to what we call open access, which means the beneficiary can see you, whether or not you are in network or not. Your claim will be processed according to fee-for-service Medicare rates and rules.
Yeah, that's exactly. You are required by law to accept, if it's a plan that covers out-of-network services or it's an emergency service, so if it's a PPO and you're just out of network, or if it's an HMO and you provide an emergency service, you are required by law to accept the amount you would have received under fee-for-service Medicare and not to bill any more. So if you are par under fee-for-service Medicare, that's, the par amount. If you're non-par, it's that higher amount, but it is what you would have received under fee-for-service Medicare. And there are penalties for not accepting or for balance billing for any higher amounts.
Okay, thank you. Next question says, what is the advantage of being in network compared to not in network? And a second parter to that question is, how do we non-contracted providers become contracted with Medicare Advantage plans? Do we contract with each plan individually?
So to answer the last part of that question, yes, you would need to contract with each Medicare Advantage plan separately. For example, we were recently acquired by United Healthcare. United Healthcare has contracts with its providers across the board for whether it's Medicare or commercial. So it's a large plan. We are in the process of working with United in order to discuss with our providers moving away from the CIP contract and re-looking at the United contract associated in order to have one contract for each plan. So United as an entity would be who you would contract with versus a Humana versus an Aetna. It is not specific to the contract with which the beneficiary is enrolled, which is based on the beneficiary's locality. So it's really the company that you're contracting with. You would have to contract with them independently. In the benefit of being a network provider is an excellent question. For an open access plan, the benefit of the contract is that you get to negotiate your terms and specifics related to how you prefer to have certain, operations work and or negotiated fees. So there are a large number of contracted providers that are paid more than 100% of Medicare. So again, that would be an advantage of contracting with a plan. There are additional benefits where if a beneficiary is contacting the plan who is enrolled and is looking for a provider, we are obligated to provide lists of providers that are local to that area, and we will include, obviously, our network providers within that list. So it does, if you're receiving and able to receive new patients, that is helpful. You are listed in our provider directory if you are contracted. You are not if you are not. So for a member who is looking for services, again, it's easier for them to find you. But again, there's several benefits to contracting. And then there are, but specifically that does obligate you to follow the plan rules, simply meaning that if the plan has a prior authorization requirement, you will be obligated to receive or to get that prior authorization prior to furnishing services. Anything you want to add on that, Kelly?
Yeah, I think that particularly as plans narrow the network, the steerage benefit or the steerage advantage can really be significant. You know, as a contracting provider in most open network plans, members will have a better, smaller cost sharing amount by going to you, and as Kristen mentioned, you will be in the provider directory, so it's likely that you will be the first provider that the beneficiary chooses versus an out-of-network provider. I think in some plans, and Kristen, you can tell me if this is the case in Care Improvement Plus, but contracted providers get paid faster because they're already in the system, so the payment may happen quicker.
Yep, that is correct. It is often the case because the provider, through the credentialing process, is sharing information with the plan that basically lets us know who you are. For example, we have several flags set up on new providers that are billing us that have not billed us before. Not only does it take us a while to obtain their tax ID, perform their NPI validation, determine that they are who they say they are, and perform other types of edits. If you are contracted and we have that information up front, your payment will go through much faster.
And I think, finally, with the star rating systems and such, and I'm not sure that at this point there aren't podiatry measures, but I'm not sure that, I think that diabetic foot care is ripe for the picking for a star rating. But contracted providers often get paid additional amounts for helping plans get their star ratings up. So that can be another advantage of being a contracted provider.
And Kelly, that's extremely important because there are a lot of items that are outside of specific specialties that are star ratings. And to your point, the star ratings do change annually. We would expect that a condition would be met for diabetics specific to lower extremity or complications to come up because it is a very costly type of care. There are lots of incentives and there are lots of hot topics going on in the industry today about how to incentivize providers to assist with not only providing valuable information to the plan that it's obligated to collect on the visits, but also to perform interventions that we know are important. So when we send beneficiaries to a physician with an Ask Your Doctor, something that we know that we would like them to discuss with their provider in order to close a gap in care, we are incentivizing based on those things. Obviously, that would only be rolled out to our contracted providers, not our non-contracted, where we would offer those incentives, and that is another benefit. So I'm glad you raised that, Kelly.
Well, thank you very much. Unfortunately, it's 9 o'clock, and that's all the time we have for questions. I'm sorry we couldn't get to all of them tonight. But Kristen and Kelly, thank you so much for talking with us this evening. It was very informative. As a reminder to all, thanks again for attending. The webinar has been recorded. It will be available by the end of the week, again at www.apma.org/webinars. And I hope everyone has a great evening. Thanks again, Kristen and Kelly.
Absolutely. Thank you so much for having me.